CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
My name is Karen Humphreys. I'm a CHÉOS scientist here, and it is my pleasure to introduce the speaker for what is actually the last WIP of 2019. So I'd like to begin by acknowledging that the land on which we gather is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Now, Dr. Conklin, who's going to be speaking to us today, has a background in health policy, epidemiology, public health, life sciences, and philosophy. She's a former CIHR postdoctoral fellow and a Gates Cambridge scholar. And actually, following her work in Cambridge, she worked as an analyst for RAND Europe in Cambridge. She holds several postdoctorate degrees, and she has over 80 peer-reviewed papers and over 1,200 citations. Now, Dr. Conklin is an expert on gender and socioeconomic determinants of diet and obesity, and her research program uses population-based data to examine how broader social level factors and their interactions shape both women's and men's diet-related behaviors and outcomes. So today, as you can see, she's going to be speaking to us about gender, sleep deficits, and teen health. Annalyn.
Thank you. Thank you, Karen. Very grateful to be here, and yes, I'd also like to recognize that I'm going to be sharing this research and knowledge on the traditional unceded ancestral territory of Coast Salish peoples. And I'm delighted to be able to share results from 2 papers, as well as a sneak peek of some work in progress as well. Can you hear me better? Is that better? Okay. Didn't realize I had to lean in. Okay, that's all good. I'll do that. So this is great because this has been a new collaboration I developed through my role at CHÉOS with Dr. Chris Richardson, who put an enormous amount of effort into developing a cohort of young people in BC. And so that's the data source that I'm going to be presenting my research on. So I'm going to just give you a brief overview about why it matters for us to consider sleep and sleep deficits in relation to young people's both physical and mental health, and offer some ideas around what are some of the unanswered questions that I was trying to address in my 2 papers. And then talk about how I was able to leverage this really great youth cohort in a way that helps answer some questions that the literature is lacking on. And then I'll present very briefly the results from the first paper and then the second paper. Those are published, so if you want more details, you can reference those. I'll give you a take-home of those 2 papers and then offer some work in progress, so as a sneak peek, and give you a sense of where I'm going next. So during the critical period of adolescence, that's a unique development stage where multiple neurological and hormonal changes lead to reductions in our deep REM sleep. It leads to more sleep disturbances and actually a shift in the chronotype of individuals towards more late chronotype. And these changes frequently result in young people not getting enough sleep or not getting good quality sleep. And in fact, it's fairly common for that to be reported by adolescents, both in terms of not getting adequate quantity as well as also feeling like there's difficulty staying asleep or falling asleep. So it's fairly highly prevalent. And so we know from population-based, predominantly cross-sectional studies that there is a strong relationship between both the quantity and the quality of sleep in terms of a number of different negative outcomes for young people. So we know that various cardiovascular risk factors like blood pressure, insulin resistance, obesity are strongly linked to either insufficient quantity or poor quality of sleep. It also affects self-reported pain, academic performance, overall well-being, and depression. But that's obviously cross-sectional, so what about longitudinal? Well, there's actually a very small amount of research in this area on the adolescent population. A lot in the adults, a fair number in much younger populations, but really not with adolescents. So we have two papers that I was able to find that were truly longitudinal, looking at short sleep as defined as being less than 6 hours in a 24-hour period. And that those two studies did not appear to show a relationship with self-reported health or a measure of general physical health. There was one paper that was longitudinal looking at adolescents and found a higher odds of depression with short sleep. In terms of sleep quality, again, we're kind of limited in our longitudinal evidence base. Only two papers I found, and both of them did appear to report a positive relationship, meaning more poor quality with worse health outcome or better quality with better health outcome. But really, it's interesting to consider prolonged exposure, because I would imagine, presumably, it's not just once that you're sleep deprived. You're probably sleep deprived on a regular basis. So what about that prolonged exposure? Well, historically, these papers that are longitudinal really only measure sleep once, and then they follow the same people up to about a year, maybe 2 years later, to look at that health outcome. It's a very standard epidemiologic approach in terms of risk factor epidemiology, but I think we need to be a little bit more advanced in how we think about our exposures. And it might be that the two different types of deficits in sleep, both in terms of quantity and quality, they may have different effects. And those effects may also differ between young girls and young boys, or young women and young men. And that may be because of biological sex differences that distinguish females from males, human females from human males, and perhaps also differences in the socially constructed gender-based roles and attitudes that could be moderators of some of these relationships. So it's really important to disaggregate our data and really look at these exposures as being potentially unique for young women versus young men. So for the first paper I'm going to present, I was curious about this question around the quantity and in relation to risk of depression, because obviously depression is quite high and growing in our younger age populations. And I also want to know, obviously, if that relationship existed, did it differ for girls and boys? And if so, kind of in what way? So that paper was published last year in M.Sc Public Health. And then in the second paper I'm going to present, I was curious about the difference then between the quality and the quantity question. So is cumulative chronic exposure to quantity, sleep deprivation, different than chronic exposure to poor quality in relationship to overall health? And then again, does that differ for our young girls and our young boys? So as I mentioned, I used the BASIS cohort. So that was established by Dr. Richardson, also a scientist at CHÉOS. He called it the BC Adolescent Substance Use Survey. So there are a heck of a lot of questions around various substances that have been used, a lot of psychometric questions, but no one's really looked at some of these other exposures that I'll be presenting on. So that was a cohort that lasted from about 2009 to 2012. There were 7 waves of data collection every 6 months or so. And there was information on school night sleep time and school night wake time, as well as weekend time, but I focused on the school night. And that allowed us to calculate sleep duration in total and then dichotomize whether individuals were sleep deprived or not at multiple time points. There was also information through the SSBS, which is a score for measuring depression. In that, there's a question around sleep quality. So I was able to pull that out, and that became the exposure just for the one paper. That was in relation to self-reported health. So again, that's around weekly occurrence of restless sleep. So do you have difficulty either falling or staying asleep? And then as I mentioned, self-rated health, we looked at that in terms of either being excellent or anything other than that. So the odds of suboptimal health. And then depressive symptomology based on the Center of Epidemiology for the Study of Depression score. So just to kind of give you a bit of a schematic of what I'm talking about, hopefully this will help give you a sense of the kind of data that we used. So as I mentioned, I used the last 3 waves, so wave 5, 6, and 7. And at each of those time points, there was information on the sleep-wake times that allowed us to calculate whether or not at each of those time points a young person reported being sleep deprived. similarly, did they have frequent poor quality sleep in terms of sort of measuring sleep disturbance? So using information at those repeated measures, we were able to calculate essentially a new cumulative exposure variable, where an individual who said no at any of those actually at all of those 3 time points became essentially our control group for comparison, looking at someone who might have responded yes, or what we essentially categorize people as being yes, they were sleep deprived at any one of those 3 time points, or yes, they had a sleep disturbance at any one of those 3 time points. That was an occasional exposure versus a chronic or more prolonged, being 2 or more, 2 or the 3. So ultimately, the analytic approach was quite similar between the 2 papers. We used multiple imputation to address missing data. We used distinct auxiliary variables and distinct exposure and outcome variables, so there's slightly different sample sizes for that multiply imputed data set. In the first study, we used a series of multivariable linear regression models because our outcome was the depression score, and then used post-estimation to get adjusted means. And those models use an interaction term for the male-female self-reported identity as a way of having gender-specific disaggregated associations. And then a number of sensitivity analyses, very similar to the second paper on self-reported health. That was a binary outcome, so obviously we used logistic regression and we did not use post-estimation for adjusted means. So results from the first paper, we did find that about 15% of the young women were chronically sleep deprived, and almost just about 30% were classified as being depressed based on a relatively high threshold for that SES score. Normally in adults, the threshold of 21 is used. So just to give you a sort of table 2, if you will, where it shows the different sociodemographic characteristics across the 3 different categories of this new cumulative exposure variable. What you can basically see from that is those who were chronically sleep deprived were more likely, a greater proportion were female, a lower proportion were of high SES based on either maternal education or household income relative to peers. They had less sleep in total, and a greater proportion were in fact depressed. Now these are obviously unadjusted analyses. So what did our modeling tell us? Well, it suggested that really chronic sleep deprivation was only linked to depression in the young women. So as you can see from this graph, I have young women on the left and young men on the right, and then you can see the adjusted mean depression scores for the 3 different levels of exposure. So absolutely no exposure to chronic sleep deprivation, far left bar, occasional middle bar, and chronic on the right bar. So all of those differences at each of the different levels were statistically significant as an interaction term. I don't judge gender differences on the basis of a statistical p-value, but if you're interested, that's the p-value. But it really suggested that chronic deprivation, a quantity question, is perhaps more relevant to mental health outcomes in young women. So what about the other paper looking at suboptimal health and the question around either chronic sleep deprivation or chronic sleep disturbance? So again, in this sample, we did find a very high prevalence of sleep disturbance. So again, that's difficulty falling or staying asleep. Fairly similar prevalence of the sleep deprived. And again, looking at the sociodemographic patterning, we did in fact also find that chronic sleep disturbance was socially patterned, meaning that we had a higher proportion of young women in the chronic exposure category, a higher proportion of white ethnicity, a lower proportion from high SES categories, a higher proportion with poor health in terms of self-rated health, or in terms of conditions, a number of different conditions, and a higher proportion with below excellent health, so suboptimal self-rated health. So when we did the modeling with chronic sleep deprivation and the odds of suboptimal health, we did not find a link for either young men or young women. There did not appear to be a clear association there. However, when we look at chronic sleep disturbance, indeed we do. We do see a relationship between the chronically sleep disturbed respondents, both for young men and for young women. And in fact, it was slightly stronger in the young men in terms of the odds of reporting less than excellent health. And that's adjusted for a number of key confounders. Again, we did sensitivity analyses. Most of our results pretty much were either minimally attenuated or really made no change whatsoever. So recognizing, obviously, this is longitudinal, and it's taking advantage of that cohort and adding to the predominantly cross-sectional literature in this area. So obviously, there's still a number of methodological considerations for both of those papers. So we used self-reported exposures and self-reported outcomes. However, with both papers, each outcome is relatively robust. We know that self-rated health does predict mortality up to 14 years, and that's across all social groups in Canada and all SES groups as well. And like I said, the CHÉOS, which is a score that can indicate depressive symptomology, that's a very well-validated, well-established outcome measure. There may, however, be some measurement error, obviously, because we didn't factor in potential information that wasn't collected around, say, napping, which may change the total sleep duration that an individual has in a 24-hour period. And we didn't have any capture in this unique exposure variable of, differences in sequential timing of problems, or whether the chronic nature was more at the kind of closer end of the outcome versus earlier on in that 12-month period of when the data was collected. There's obviously always residual confounding. That's not something I can ever avoid. But our findings were fairly similar to the very few studies that do exist out there. So still feel fairly confident with the findings that we found. So some take-home messages trying to wrap up those two distinct papers. One is sleep does matter for youth health, but we know still very little around cumulative impacts or prolonged exposures, or whether or not there are differences by gender. Even the cross-sectional literature very rarely looks at whether or not sleep duration or sleep quality differs between young men and young women. So we did find that chronic sleep deprivation was only linked to the risk of depression in the young women in this cohort. And the almost 5-point difference in the average, the adjusted mean SSBS scores between the young women who had chronic sleep deprivation and those without was actually a medium effect size and could be clinically significant. Chronic sleep disturbances over that 12-month period were linked to self-reported less than excellent health. And in fact, as I mentioned, those relationships appeared to be stronger in our young men than our young women, but both of them had almost 2 times a higher odds of suboptimal health when they reported being chronically sleep disturbed. So key take home from the first paper is, or the second paper, sorry, this last one I talked about, really if we want to promote the health of young people, we're going to need to have strategies that are addressing chronic exposure to having difficulty staying or falling asleep. Now, some of that may be through sleep hygiene recommendations and practices, parental guidance around sleep times, but it could also be changing the start time of schools, which has been examined in the States in one location and does appear to be very effective and very helpful for young people in both their cognitive performance and overall health. And our mental health strategies really need to consider helping or supporting young women in actually achieving what is supposed to be sleep recommendations. Young people in an age group of 13 to 18 should be getting between 8 to 10 hours per 24-hour period of sleep. I can assume that most of us don't really get that recommendation achieved on a regular basis. So some new work, because this is a work-in-progress seminar, so rather than give you an update on things that are already out in the literature, and you're very welcome to download the articles for interest. So I have a master's student in human nutrition program, Texan, who is looking at social jet lag. So I've talked about quantity, I've talked about quality, but what about timing? So that's the idea of social jet lag. So most of us during the weekday are pretty sleep deprived, more so than on a rest day. The rest day being a weekend, or perhaps more likely when you're actually on holidays and not still doing work, you might sleep and wake and sleep at slightly different times than your social environment prescribes for you to do. So that difference is what has been termed social jet lag. It's that absolute difference between the amount of time you're able to sleep on a weekday versus a free day. And that work was done quite a while ago in the early 2000s by Ronenberger and colleagues. And so this is unlike the jet lag you get when you're traveling and crossing time zones, in the sense that that's kind of a temporary jet lag. But throughout your working life, you are exposed to this difference where socially you may be expected to come to work from 8 to 4, 9 to 5, 10 to 6, or whatever that time is, and that may not match your natural chronotype, your embedded biological clock. So it's essentially that difference between your social and your biological clock. And why does this matter? Well, for young people, they are most acutely exposed to social jet lag, because naturally they shift to a late chronotype, and yet our school times are very demanding in terms of 7 a.m. starts or 8:30 a.m. starts or whatnot, depending on where you are and what your location is. But pretty much, if most teenagers probably, if they had the option, would probably sleep into maybe midday, certainly late morning, would not be getting up naturally for a 7 a.m. unless perhaps they are that chronotype of the early bird. So social jet lag may be relevant to eating behaviors in a number of different ways, and particularly eating behaviors around high glucose, high energy types of items, such as sugar-sweetened beverages. That may be because social jet lag could alter the circadian control of hunger, of metabolism and detoxification, of hormone release. All of these factors work in harmony together. So having done social determinants of health work on diet quality and obesity, a lot of the conversation is focused on diet and physical activity for obesity. We don't really have a discussion around sleep. And I think sleep and diet are intimately related and need to be investigated in that way. It may also be that social jet lag, when you're pretty tired and you're coming into work, that might trigger you to find high energy intake items. For most of the adults in the room, that's probably caffeine. So when you're feeling tired, what do? You probably go get a new cup of coffee. For young people, that's probably an energy drink, right? Red Bull, whatnot, Bolt. It might be actually just pop and Coca-Cola, because it helps you kind of give you that sense of, okay, I'm boosted, I've got more energy, but essentially it's a little bit artificial, isn't it? So here's my attempt at trying to pull all this together, adapting a conceptual framework from Jeffrey Sobol around determinants of obesity. So this is how I'm envisioning these relationships. Very open to discussion around this and what your thoughts are, but essentially, food and drink intake, as well as other behaviors like MVPA, which is moderate to vigorous physical activity. Both of those do influence energy balance. But our basal metabolic rate is also influenced by our circadian clock, as is our sort of stress response pathways, and all of those are interlinked and may have bidirectional relationships, ultimately all leading to potentially excess body weight and weight gain, which is a serious concern that we're dealing with public health-wise. So what's happening in BASIS? So at wave 6, this is going to be a cross-sectional study for my master's students, starting just to see, is there a relationship before we start interrogating prolonged and cumulative exposure questions. But what you can see from this graph is the average sleep duration across the different age groups. So in BASIS, we have 13-year-olds to almost, 18 and a half, 19. And you can see from the blue line that that's the average sleep duration on a free day on the weekend, versus the red line, which is the amount of sleep that the young people in BASIS are getting on a work day, on a school day. Mm-hmm. And that difference for most of the ages between 14 and about 18 is about a 1-hour difference. So there does appear to be some social jet lag experiences that could be happening in this cohort. And this cohort is representative of the young people in British Columbia across the province. So at table 1, what does our group look like at wave 6? So I've just kind of highlighted and bolded a few areas to draw your attention to. So in terms of the boys or the young men, a higher proportion report having a mother who has a bachelor's degree or higher, so highest maternal education, which is a very strong determinant of diet quality and obesity. Slightly lower proportion of the young girls are coming from a high SES background. So in terms of poor quality sleep, a higher proportion of the young women are reporting poor quality sleep. And there does appear to be a higher SSB, sugar-sweetened beverage intake, in the boys compared to the girls. And a higher proportion, though, of the girls are then meeting the SSB recommendations. That's about essentially kind of 1 can of Coke a day, pretty much, not much more. I'm sure most of you who do know young people, that's not their average consumption. So in terms of considering social jet lag and different levels of social jet lag, so in terms of tertiles going from low social jet lag, less than about an hour, to an hour to 2 hours, and then above 2 hours, we do see a little bit of social patterning across those different tertiles of social jet lag. So not really many differences around total sleep time. Some differences around sugar-sweetened beverage intake. Noting, though, that this table is all of them. It's not separating the young girls from the young boys. And we do see some differences, again, with some SES variables and screen time. So higher screen time in those who are most socially jet-lagged, meaning more than two or more hours difference between the work day and the free day. So that's my kind of sneak peek of what's to come. Hopefully I'll be able to present that, or my student would be able to present that in due course. But I'd like to acknowledge, obviously, all of the young people and the schools that were amenable to running this study over quite a few years. And obviously for the CIHR funding for that cohort, which has now opened up a huge data source for this work. And then my co-authors, predominantly Chris Richardson and my previous RA. So I welcome any questions or comments. Thank you.